How do you think these tests will be used in New South Wales to allow Year 12 students to return to the classroom in 2 weeks' time?
Well, it's an interesting model. Certainly, we've helped roll it out in Widnes, as you showed on your segment just now, at aged care and in clinical settings. Certainly, any high-risk area, particularly if we can repeat the testing again and again, can use this form of testing. So in a school environment, absolutely. As long as you do it at the front entrance to a venue, make sure it's done in a controlled way and you have good protocols about what to do when somebody's negative and when somebody's positive, then I think they can be done safely.
Why hasn't this been widely rolled out in Australia already? And we saw there in that piece that you can get them on the streets for free in places like London.
So I suppose best to look at the WHO recommendation on these tests. They're very clear. It's a useful PowerPoint to look through as when a country should look at implementing. When you're in the elimination phase early on, and thank goodness in Australia we've been in that phase for many, many months, then PCR is the test to go to. And that's the case when there's no or very little spread, or even when there are small clusters but it's well contained, PCR is still the right test, particularly when we're tracing elimination or zero spread. When we go into an actual outbreak, and this is the context across UK, Europe, the US and other places, that's when the WHO recommends we move on to rapid antigen tests layered on top of PCR. We're not saying get rid of PCR, it's an added tool to be added in now.
Well, especially considering that in parts of southwestern Sydney, there is already surveillance testing taking place.
Correct, but and then it's a question of actionable intelligence. So if you are doing surveillance testing, for example, using PCR, and yet you don't get your result for 24, 48, 72 hours, then that's actually not a useful tool to stop this outbreak currently. We need tests that may not be exactly as sensitive as PCR, but can be done very, very quickly. It's down to as fast as 10 minutes. And because if you repeat less sensitive tests more often, they actually come up to equivalents of the more sensitive test. So they're absolutely useful. That's why they've been rolled around the world in the tens of millions.
Is there any sense from you that the reason why Australia hasn't moved quicker to adopt rapid antigen testing and have this officially approved for use is because of lobbying by pathology services?
Well, certainly in Australia, we've had 15 to 20 years of hesitancy, I think, around point-of-care testing. So this is from a family of tests called point-of-care tests. They're delivered at the bedside or in the GP practice or by a nurse practitioner at another venue, at a clinic. They've always been hard to get in place in Australia. It's a historical thing. We had problems even with pregnancy tests and hemoglobin measurement of glucose attached to it. So for control of diabetes, for example, it's a historical thing. So it's not surprising there's always been hesitancy. And yes, there's an element of wanting to go into a professional quality system through the laboratory. We understand all that. There's hesitancy because they're not sure the reporting will definitely go back into the public health system. Those can all be addressed about quality and about reporting, even with an antigen test. And I think it's time now to look at that.
What about the risk of false positives from the rapid antigen test, which I guess is probably a better outcome than false negatives?
Yeah, so we can certainly tolerate false positives. This means that if I come to you and have my test and it looks like it's positive, this is not a diagnostic test. It's very clear. This is a screening tool, and then you will go and get a confirmatory PCR, but it does defend the PCRs for those who need it most. But the fact that can be falsely positive is quite rare. So the product literature, if you were to open one of these boxes and read it, it says about 99.3 to 99.7%. So very low risk. The real life example, we were assisting up in OSMAT up in Howard Springs for many, many months, rolled out about 30,000 tests. There were 3 false positives at an entire time from 30,000. So it's not a big deal.